Welcome everyone to our uh, monthly presentations, research presentation, and I am delighted to invite back Dr. Yair Blumenfeld to speak to us today. He is professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine and Obstetrics, and well known to many of us here on Zoom. Dr. Blumenfeld did his undergraduate at UCLA, majoring in microbiology and molecular genetics, and he graduated cum laude. He then went on to the medical school in Israel at the Sackler School of Medicine, a residency at Mount Sinai in OBGYN, and then we were fortunate enough to have him join Stanford, where he did his fellowship, and very early on developed an interest in prenatal diagnosis and prenatal diagnostic technologies, did some seminal work with Steve Quake, and published in the Proceedings of the National Academy of Sciences, non-invasive diagnosis of fetal aneuploidy by shotgun sequencing DNA from maternal blood, and really kind of led the way with Steve Quake's lab in the current revolution that we have with non-invasive prenatal testing. His interest in prenatal diagnostics and fetal therapy resulted in time spent at Texas Children's Hospital under a formal agreement that we established with Texas Children's, and Yair gained a lot of skills in Texas and brought them back to Stanford, where he really led the way in launching our fetal therapy program, and in a very short period of time has truly transformed what we have been able to do in the fetal and pregnancy health program that Dr. Susan Hintz leads. And Yair is our director of fetal therapy, working closely with Dr. James Wall and Dr. Carl Sylvester in that area. He now has pretty much introduced every single fetal therapeutic that there is to Packard, and launching the last, which is Feto, hopefully in the near future. He has authored and co-authored nearly 90 peer-reviewed papers, has leadership of the NAFNet site at Packard, and was one of the main contributors to the RAFT study, and in fact is here today to talk to us about fetal lower urinary tract obstruction and development of a novel shunt. A couple of updates before I let Dr. Blumenfeld lead the way here. We have a couple of symposiums, one symposium coming up on October the 14th, Harnessing Data and Community Voices to Improve Maternal Health. It'll be via Zoom with in-person happy hour to follow. There'll be keynote speakers, speed talks, and breakout rooms. And then our next presentation will be by Dr. James Wall, who helps lead the Stanford Biodesign program. So without actually, I'm going to have Anna give one last presentation here real quick.
Yeah, one last reminder about our fall seed grant cycle. It's open for applications and due on October 3rd. It's $35,000 for 1 year. Just these are the eligibility criteria. I just wanted to highlight that we're funding proposals that are advancing the science of maternal fetal medicine. And if you're interested, there's a link for more details, and you can apply through the Dunlevie MFM.stanford.edu. It actually links you to the seed funding website hosted by the university. I'm happy to take any questions, or so feel free to email me.
Thank you, Anna. Okay, Yair, the floor is yours.
Thank you. Let me share my screen. And Yasser, thank you so much. Your introductions are always so heartwarming. You know, I like to think and say publicly as much as I can that, you know, I learned medicine, you know, in Israel and in New York at Mount Sinai, but I think and truly believe that I learned, you know, how to be a physician, and hopefully a reasonable one, here at Stanford. And a lot of that was because of you and Maury and Susan and so many others on this phone call. And I'm really just, honored to lead this fetal therapy domain under the Dunlevie Center, which you've shepherded, in an unbelievable way. And hopefully we can move, the science forward in this domain and via collaborations with many others on this phone call. So just thank you for, all these wonderful introductions every time I get an opportunity. So with that said, this is the title of my presentation, and I know that many of you on this, or at least some people on this meeting, know something about LUTO. Some of you know a lot about LUTO. Some of you have never heard about LUTO. So hopefully I can get everybody to a reasonable level at the end of this presentation and tell you some of the exciting things that we're working on to try to move the science forward. All right, so I think it's important to recognize, and I won't spend too much time on embryogenesis, but these kidneys that we're focused on develop really early in gestation, often before the pregnant patient knows that they are pregnant. And really this sort of intricate development happens early on, and we can start to see the kidneys even as early as 10 weeks, and studies have shown that you can even see the kidneys as early as 8 weeks. But they really don't function to supply the amniotic fluid until after about 16 weeks. And until that time, most of the amniotic fluid that we see is, people think it comes across the placenta or transudate. Nobody really knows how, but it's certainly not supplied by the kidneys. And renal anomalies globally represent a fair amount of the total anomalies that we see, affecting up to about 0.5% of all pregnancies. And as a reminder, when we think of structural birth defects, about 3 to 4% of all pregnancies are complicated by those. But early onset renal failure, which certainly LUTO is a part of, is rare, about 1 in 2,000 pregnancies. The prenatal diagnosis of LUTO, especially when it's severe LUTO, is not subtle. And these are a few of the images. So you can see this large, for those of you who are not performing ultrasounds as a part of your daily routine, you don't have to be a scientist or a clinician to know that that black circle in the middle of the image on the upper left should not be there. And you can see in the picture on the right-hand side, the picture, the size of this enlarged bladder compared to the size of the fetus. And in this picture here, you can see that the kidneys, when you get a glimpse of them, are already fluid filled. So LUTO stands for lower urinary tract obstruction. It affects about 1 in 2,000, maybe up to 1 in 3,000 pregnancies. And when you have a complete obstruction, what ends up happening is you have backwards flow of the urine. It starts putting pressure on the kidneys, fills them with fluid. We call that hydronephrosis. And then over time, when there is a complete obstruction, we will see a decrease in the amniotic fluid level. And LUTO is a finding. It's not a diagnosis. There are several underlying etiologies, which I'll show you in a second. But the bottom line is that you have an obstruction in a really, really small part of this small fetus, which is this bladder outlet. And that little abnormality leads to one of the most lethal anomalies that we have in prenatal medicine. And a lot of that is because, or a lot of the lethality is because when there's low fluid around the baby over time, starting very early on in the pregnancy, the lungs just don't develop well. And as soon as these babies are born, they're just not able to adjust to the outside world. So as we said, LUTO is a finding. It's not a diagnosis. The most common underlying etiology are these small membranes which obstruct the urethra, or the outlet of the bladder into the urethra, called posterior urethral valves. These are gross images and histology from one of our cases that ended up terminating. And you can see actually on the image below, this is a kidney that is already quite damaged, and this was from approximately 16 weeks. But there are other etiologies. There are rare anterior urethral valves, and then there's a variety of conditions which prevent the urethra from forming well, and that could be either atresia or stenosis. These can be seen in females, posterior urethral valves most often in males. And then there are other disorders which can mimic an obstruction. One is a cloacal anomaly, which essentially the entire pelvis doesn't develop well. or the way that the pelvis gets divided between the GI tract and the urinary tract. And then there is this syndrome called prune belly syndrome, which is most often secondary, where there's a weakening of the abdominal wall as a result of this very dilated bladder. But there's also primary prune belly syndrome, where the innervation of the muscles doesn't occur appropriately in the anterior abdominal wall, and they're very lax, and therefore there's no pressure to compress the bladder over time. And unfortunately, when we perform ultrasound, we don't know what the diagnosis is. Genitourinary and pulmonary effects are linked. And so the figure on the right-hand side goes through the various developmental stages of the lungs. And I just showed you pictures from about 10 weeks. And you can see this is, during the pseudoglandular phase. This is a very important stage here between 16 and 24 weeks called the canalicular phase. And you can see all this development that needs to occur in the lungs. And if we start to have decreasing fluid here, this is really the issue, which leads to a significant amount of lethality in these cases. And so this long-standing oligo, which means decreased, or anhydramnios, which means absence fluid, is really what causes this pulmonary hypoplasia. Of course, over time, with the bladder distension and the backwards flow of urine, these babies do also experience significant renal failure. And the mortality is, again, because of these two causes. But nowadays, our neonatology colleagues and nephrology colleagues have made amazing advances in the field of neonatal dialysis and transplant. These are now a possibility. And so really the focus of in utero therapy has kind of transitioned over the last couple of years to focus more on improving pulmonary survival. Meaning, if we can improve the likelihood that a child will be able to breathe after birth, then our colleagues can hopefully manage the significant renal impairment that is for sure going to occur along with this syndrome. And so the idea of shunting or performing something called a vesico-amniotic shunt, meaning placing a shunt between the bladder and the amniotic cavity, is not new. The early studies started as early as the 80s and the 90s, and the shunts that we use today were developed at that time. And the idea was to simply bypass this obstruction at the bladder outlet. So if you can put a conduit to go between the bladder and the amniotic cavity, over time, if the kidneys are functioning, one would assume that the amniotic fluid would increase and therefore help with pulmonary development. Of course, time has shown, and several studies have shown, that there's unclear, if any, benefit on renal impairment over time. A part of the renal impairment is not only the kidneys themselves, but also the bladder. And until recently, that has sort of taken a back seat. But with this new shunt that I'll show you a little later, we're focused on that as well. So this is what severe LUTO looks like at 16 weeks gestation. So you can see the bladder is very, very enlarged. Usually when we measure the size, it's above 100 cubic centimeters. And you can see it's like 10 by 5 centimeters here. You can see that, or at least take my word for it if you're not used to performing ultrasound, that there's no fluid around this fetus. And again, you can see that the kidneys already have significant fluid within them in this picture here, and that's the hydronephrosis. And we can even see the hydroureter, the dilated conduits which connect the kidneys to the bladder. These are the shunts that we use nowadays. There are two varieties. The shunt on the left was developed in Europe by Charles Roddick and his colleagues. It was then bought by a company and is manufactured and marketed as a rocket shunt. And the shunt on the right was developed at UCSF by Michael Harrison and his colleagues, and is therefore called the Harrison shunt. The rocket shunt is a little stiffer. It's a little larger. The Harrison shunt is a little smaller, a little more malleable. And hopefully you can get a sense that these trocars, even though they're quote unquote relatively small, clearly in order to place the shunt, you need to introduce these trocars through mom's skin, through the uterus, into the amniotic cavity, into the fetal bladder, deploy that part of the shunt, pull back on the trocar a little bit, and then deploy the part of the shunt, which then goes in the amniotic cavity. And as you can imagine, when you start placing sharp instruments like this through mom's abdomen and uterus and into the fetus, complications can arise. And this is what it looks like. So the picture on the left is an ultrasound, and you can see the dilated bladder, and the introducer goes in the middle. And then you can see the part of the shunt, which then gets under ultrasound guidance placed into the bladder. And then the picture on the right, you can see the shunt is curled up on the inside, and you can see a little bit of the shunt on the outside. And when you start to look a little closer at this picture, this dark area here, this thick area is the bladder, okay? And the bladder, where previously it was very dilated and thin over here, becomes very thick, and it stays like this, compressed during the entire pregnancy. And what our colleagues have known, and what MFMs are becoming more attuned to, or our pediatrics colleagues have known, is that this bladder dysfunction, of course, is an issue postnatally, but if the child ultimately needs dialysis and then transplant, having that dysfunctional bladder stay there can then affect the normal kidney that was then transplanted because of this very dysfunctional bladder cycling, which happens as a result of this decompression. The other thing I just want you to pay attention to in this picture on the right-hand side is that, yeah, you can see the part of the shunt which is in the bladder. Maybe you can make out the part of the shunt that is outside, but you really don't see sort of the connection between them very well. And that was one of the issues that when we developed this shunt, we wanted to really improve the echogenicity factor, so that when we place these under ultrasound guidance, we can improve the deployment, the technical deployment of these shunts. And so this is, again, what it looks like. You can see the dilated bladder on the left-hand side. There's a classic, this is called a keyhole bladder that people assume is related to posterior urethral valves, although we've seen it with urethral atresia as well. And the point of this picture, again, is here's the part of the shunt that's outside the baby, the part that is inside the fetus, excuse me, in the compressed bladder. But you can see these kidneys are still showing a sonographic sign of hydronephrosis and hydroureter. So we're not really necessarily affecting the trajectory, or at least we don't know very well whether we are or not. When these shunts were developed, there was a lot of interest to see whether or not they are clinically beneficial, and a prospective multi-site study out of Europe was then undertaken with a beautiful acronym called the LUTO trial, which you can see what it stood for on the upper right there. And essentially it was an attempted randomized trial comparing shunting to conservative treatment. The criteria were large bladder or megacystics, a keyhole sign, renal dysplasia, but they didn't necessarily include having evidence of oligohydramnios, meaning that some of these cases may not have been complete obstruction, but maybe a partial obstruction LUTO. So not necessarily comparison of apples and apples. The study, unfortunately, was closed due to poor enrollment, probably because it was hard to enroll people in an expectant management arm, or at least convince them of that. And probably the people that were conducting the study had a bias towards intervention. But be that as it may, they were able to allocate 16 to a vesicoamniotic shunt group. You can see 3 of them crossed over to conservative management, and the 15 that were randomized to conservative, 2 of those ended up getting a shunt. So it's not an insignificant crossover for those of you who are interested in trial design. And these were the outcomes. So you can see this is survival outcomes in this very famous LUTO trial, which was now published, almost 10 years ago and took many, many years to complete. But you can see that, first of all, in terms of the live births, again, 12 out of 16, so 75%, so certainly not 100%. You can see survival within a month drops precipitously to 50%, again, only 1 month, 50% in the shunt group, and much lower in the conservative group. At 1 year, you can see it drops further, many with significant renal impairment. And at 2 years, you can see the numbers there. Because it was such a small cohort size, again, these did not necessarily reach statistical significance, but you clearly start to get a picture that there may be a benefit for shunting. And the other thing that hopefully I can impart on you is that you can see that in survivors, there's clearly a significant risk of moderate renal impairment. And when you look a little deeper into the data that were published, and there are also subsequent data, but in the interest of time, I wasn't able to include them here. This is the survival data. I just want to show you one more picture here, this was the intention to treat analysis. And those numbers that I showed you before, 7 out of 16 in the shunt group versus 3 out of 15. For those of you guys who like relative risks and p-values, you can see those here. Whereas in the as treated, meaning if you counted the ones that were actually shunted in the conservative group, you can see that the survival with shunting was 8 out of 15 and 2 out of 16. So, and this did reach statistical significance. And the point is that even with shunting, with this study, where they probably included people with, or at least some participants in the more milder range of the spectrum, mortality risk at 2 years is still quite significant. And highlighting renal impairment, and this is only at 28 days, there were subsequent studies showing significant impairment beyond this. Again, you can see that even in the vesicoamniotic shunting group, you only had 2 out of the 8 survivors have normal renal function, and the rest had anywhere between mild and moderate at 1 month, and it got worse over time. As I alluded to previously with these trocars, and this is true for any fetal therapy that we perform, we want to present it in a way that the pregnant patient understands that clearly there are bleeding risks, infection risks, trauma to the fetus, bladder rupture, shunt migration to nearby organs. There are obstetrical issues to deal with, including infection and preterm labor. As a reminder, the fetus is surrounded by 2 membranes, the inner amnion and the outer chorion, so you can have separation and rupture of the membranes, and then placental abruption. But really the Achilles heel of these shunts is really shunt migration and clogging, necessitating repeat interventions. And each one of those interventions carries, again, the same risk of bleeding, infection, and obstetric complications. So when we counsel patients before the shunt, we tell them that more often than not, it's not a one and done. It is not a procedure that we perform once and then you won't need it again. And again, it's only palliative. It doesn't help us with making the diagnosis. We're not able to say, yes, this is posterior urethral valve, or yes, this is urethral atresia. And I didn't include the data here, but the prognosis is quite different between those 2 diagnoses. There are some recent data informing us whether we should be shunting LUTO cases with normal fluid. Again, some of these were included in the Pluto trial. These are data from Texas Children's. And I want to just show you this really quickly. Out of 18 cases that had normal fluid at mid-gestation, about a little under half maintained normal fluid until delivery, did not require a shunt. And in those, they still had 1 case, or about 20%, that required dialysis, not just moderate impairment, but actually neonatal and child dialysis by 2 years of age. So even when you have normal fluid, and we have cases like this at LPCH, you're not out of the woods. In those cases that developed oligohydramnios in the 3rd trimester, 4 developed late, did not receive a shunt. All those survived, but again, you saw about 25% risk of renal impairment requiring dialysis, and by 2 years, 50%. They had 6 that the fluid was preserved, and then they had 1 that had oligo that declined a shunt, and that baby died from pulmonary hypoplasia. So I think these data at least prove to us that we should not be jumping to shunting in patients with a normal amniotic fluid level at mid-gestation. Initially, when people started studying LUTO more closely, there was a lot of excitement for vesicocentesis, or at least serial vesicocentesis, as a way of prognosticating renal failure. The thinking was that if we just place a needle, not a shunt, into the bladder and we drain it, and we look for a variety of analytes, we can then come up with certain criteria or levels below which we can then conclude that there is in utero renal failure. And this sort of vesicocentesis with analysis of renal analytes became a part of the paradigm for many years. And then more recently, there have been data suggesting that looking at these analytes is not necessarily beneficial or as informative as originally thought. And there's another marker that is probably better than analytes, which we use as well, which I'll show you in a second. In this study from Texas Children's, again, Rodrigo Ruano, They looked at 8 cases of LUTO that ended up having intrauterine renal failure and compared them with 17 that did not have in utero renal failure. And of the various prognostic factors, including the way the kidneys looked at, like whether they had hyperechogenic cysts or whether there was evidence of renal dysplasia or whether there were favorable urinary analytes, the best predictor was really the way the bladder refilled after performing vesicocentesis. Meaning, if you just place a needle, drain the bladder, and come back a few days later, if that bladder refills, that is probably the best predictor that there is still some renal function that could warrant shunt placement. Again, the thinking is that if there's already renal failure, we should not be placing a shunt given these complications, because if the kidneys are not making any urine, there's no point in placing a conduit between the bladder and the amniotic cavity. About 10 years ago, there was also a fair amount of excitement about fetal cystoscopy. And fetal cystoscopy is the sort of mainstay evaluation tool in the neonatal period, where our pediatric urologist places a scope in the bladder to try to figure out whether there's a atresia or posterior urethral valve. And people tried and successfully attempted a fetal cystoscopy. So instead of putting a shunt in, they put a camera in the same way that we perform fetoscopy for laser ablation for twins. And what they showed in the initial studies was that A, you can get a fetoscope in, B, by aiming the fetoscope at the bladder outlet, you can identify whether it's a posterior urethral valve or something more severe like urethral atresia or stenosis. And if it was a posterior urethral valve, they attempted putting in a laser, much like our fetoscopy, and ablated the valves. And in their original papers, Rodrigo and Nicholas Sananis from Strasbourg suggested that they could identify the anomaly and actually primarily treat the problem. The problem was that after several attempts, they realized that you can have significant complications, meaning you're aiming the laser, which is this red dot over here, at what you think is the posterior urethral valve, and you fire this heat in a very early gestational age fetus, and you can actually create a fistula between the bladder and the skin. And so this kind of put a moratorium a little bit on fetal cystoscopy. And subsequent studies, this is from the Yves Ville's group in Paris, by performing elegant MRI studies on LUTO cases, what they showed was that this angle of the bladder neck, and this is elegant for us and probably very elementary for our pediatric urologists and neonatologists, but the problem was that this angle is so sharp that using existing cystoscopes would not be of benefit, and it's not surprising that you have these complications. And there are several groups now around the world working on optimizing the tools, a fetal cystoscope, to try to optimize that. Several years ago, Rodrigo came up with a proposed staging system. This is not necessarily standard of care around the world, but I wanted to make you aware of this, where he came up with a stage 1, a stage 2, and stage 3, based on the amount of amniotic fluid, the sonographic appearance of the kidneys, urine biochemistry, again, that's fallen out of favor, and whether or not intervention should be taken. And for the mild stage with normal fluid and no other factors, expectant management was suggested. For stage 2 LUTO, where you have sonographic findings and other findings suggesting of disease, but still evidence of renal function, the suggestion was to perform a shunt. And then with stage 3, where you already have end-stage renal disease, then suggestion was for either amnioinfusion or something else. And this is just another way of looking at it. This subsequent study, he took it all the way to stage 4. And I just wanted to highlight this for 1 second, where we have early onset LUTO and hydramnios. Here he put unfavorable biochemistries, but for us now it's drainage of the bladder without any reinfusion. Then really right now, we're still a part of the RAF trial, which Yasser alluded to. It's the renal and hydramnios fetal therapy trial, which is a 2-arm study, one looking at bilateral renal agenesis, which is a separate disease, but the other arm looks for early onset in utero renal failure from other etiologies, including severe LUTO. So if you do see a case of severe LUTO or hear about where there's evidence of early onset renal failure and they're not a candidate for shunt, they're still a candidate for this arm of the RAFT trial. There is a moratorium on the bilateral renal agenesis arm. We'll have more information about that in the coming weeks. And Rodrigo then proposed that despite these stages, one could go from stage 1 to 2 to 3 to 4 during the course of the pregnancy. With all of this confusion about prediction and other things, there is a consortium underway in Europe trying to incorporate some novel peptides and mRNA and novel imaging to help us predict in renal impairment in these cases. This multi-site study is ongoing. I don't have any further evidence, but for those of you who are translational scientists on the call, just know that people are looking for other biological markers, including maternal serum, to try to help us understand what is happening in the fetus in these cases. So the question is, who to shunt, if at all? Several people, very prominent fetal therapists around the world, looked at the Pluto trials, and their conclusion was actually that we shouldn't be shunting anyone. Their conclusion was that, you know, there's no benefit to shunting for any reason, and they opt not to do that. I think that's kind of in the minority around the world, and we're of the belief with others that there is a benefit, at least from a pulmonary survival, but unclear benefit in those with normal fluid. And we still don't know the ideal time and whether we can predict. And so as of today, the optimal candidates in our institution is isolated LUTO, no other structural anomalies or genetic syndromes, a dilated bladder, usually 50 cubic centimeters, but there's no line in the sand. We do perform an initial vesicocentesis for 2 reasons. One, to look at bladder refilling, and the other, we send the fluid for genetic studies, including fish studies, to get rapid results for the common aneuploidies. We do want to see evidence of oligo or anhydramnios suggesting that this child would be at risk for pulmonary hypoplasia. We perform these shunts at least at 16 weeks. And the most important thing I can highlight is our multidisciplinary approach. This is not a 1-person or 2-person sort of care. We coordinate a lot with our neonatology colleagues and genetics colleagues, nephrology, urology, and many others. I showed you the morbidity on an individual case, but there's clearly, you know, based on neonatal complications, including prematurity and renal failure, when you start adding the numbers, and we worked with a health economist and his group, looking at some of this, there's a significant burden related to prematurity in these cases. Again, if you perform several shunts, it's not surprising that you'll have prematurity. And then the long-term renal failure, and these are per year expected in the US related to this, from dialysis and transplant, could be well over $1 billion. And so we felt like there was a significant opportunity to improve these shunts, change the trajectory, maybe reduce the likelihood of renal failure by 50% because of the inherent technical challenges of these shunts, and lead to some cost savings globally. And of course, the focus is on improving the clinical outcome on the individual basis as well. And so the shunt development sort of is a multidisciplinary team effort. Kuhn Sheth is a pediatric urologist. Eric Johnson is an engineering lead consultant who is a longtime friend of James Wall, who you see there on the right, the head of the pediatric biodesign program. And Enrico Danzer is a pediatric surgeon who was here and has a lot of interest in colleagues who do fetal medicine, but has since moved to Memorial Sloan Kettering to perform pediatric oncological surgery. And this was our initial development and the initial prototype. And this was based on the anchors that you see there, based on ASD device closures, which we took off the shelf and placed them with this coil reinforced conduit and inserted this proposed one-way duckbill valve, so that the idea was that once you insert the part of the anchor into the bladder, by having the valve there, it would only open up beyond a certain pressure gauge within the bladder and help hopefully with this bladder cycling to reduce the bladder morbidity, which I spoke about earlier. And after designing this prototype, we performed this benchtop assessment of the pull force that would be required to get it out of the bladder. And you can see when you compare with a Harrison and the Rocket shunt, the Vortex shunt took a lot more force in the benchtop testing to pull out. And again, we think that this sort of improved fixation can lower the risk of shunt migration over time. And the initial studies were performed not only in benchtop, but tabletop. And you can see this sort of plastic square. This is actually a pig bladder fixated, and we inserted the shunt using ultrasound guidance. And let me just play this again for you. The nice thing here is you can see the part of the shunt which goes in is very nicely echogenic. For those of you who are used to doing fetal therapy, there's the bladder on ultrasound looks identical. And then we place this dye test to sort of prove that the shunt was in place. And these were in benchtop testing studies. And then we looked at the kinking and the extension. And the thinking is that when we place existing shunts in a 16-week or 18-week or 20-week fetus, over time that fetus is going to grow. And especially as the bladder compresses, the distance between the skin and the bladder is going to change. As the fetus moves, the shunt is going to move. And we wanted these shunts that have high bend and are not likely to kink. And we performed some studies showing those as well. And finally, we did benchtop testing looking at this one-way silicone valve and the amount of water pressure that it would take to overcome the valve. And it ended up being 20 millimeters mercury, which is similar to the bladder outlet pressure necessary in neonates. So we obviously like that. And so our value proposition was that if we can decrease the complication rate, we can, of course, improve the morbidity related to prematurity, but maybe we can even then expand the market to all other kinds of LUTO, not just those with decreased fluid, maybe those with normal fluid, because the risk-benefit calculus has changed. And by putting it in those cases, maybe we can reduce neonatal renal impairment as well. So when we started the project, we received some funds from different sort of medtech consortiums, including the Stanford UCSF Pediatric Device Consortium, and even a private donor that was excited by the idea. And then we presented this at the North American Fetal Therapy Network and followed up with our colleagues around the country and some even around the world to try to get their input. And for the most part, they were excited by the initial design, with one person saying, oh, I don't believe in shunting. And obviously we didn't have any further discussions with that physician. And we published the initial prototype in Prenatal Diagnosis, and you can see the reference there if you want to take a look at that manuscript last year. So we said, okay, this was a nice prototype. Let's take it to the next level. And so Eric was playing around a little bit with some 3D printing, which is nice for manuscript, but it's not quite ready for the next phase. But we did develop the next sort of shunt. And this is, I guess, for lack of a better term, Vortex 2.0, where now the nitinol ends are no longer ASD devices, but rather custom made. The way they're fixed to the flexible covering is now a lot more optimal because they're custom. And then you have these sterile, the steel ends, which you can then shave down and make them really atraumatic. And you can design these ends to whatever size you think is best. And then we developed a delivery system, which of course looks rudimentary here, but it's based on a delivery system for IVC filters. And the idea is that these shunts are going to be preloaded into canisters. And the most important takeaway from these novel delivery systems is that the caliber, the width of these mimics existing shunts. So we will not need a bigger trocar than what already is done today. So we were excited by that. And so then we took this new shunt back to benchtop testing, and you can see it's just as kink resistant. And then we no longer had fetal bladders, but other sort of mechanisms to test that. And then we realized that one size should not fit all. And while existing shunts come in one flavor, we know that there's different size fetuses and different indications, whether it's not just for the bladder, but we use these shunts for pleural effusions. And we realize that we can make different sizes. So we realized that we want to go from preclinical to animal testing. And we started calling around the country and actually around the world, seeing if somebody has access to sheep. Unfortunately, at Stanford, there is no access. We started calling and different labs that we know and having discussions. And very fortuitously, Enrico is in contact with a group, a very prominent group at Leuven, Young Depressed Groups, which has done a lot of studies at other pathologies, and they created a surgical LUTO model in a sheep because they were very interested in understanding the pathophysiology. And so this is what their LUTO model looks like. So these are ultrasounds of this sheep model. And you can see this is a dilated fetal sheep kidney, which looks exactly like the human. This is the dilated bladder, which looks just like the human. And these are sheep fetuses. So the surgical model is created at about halfway through gestation. This, if you look closely, this is actually the penis that is cut off. That's how they make it. And it looks identical. And so Enrico was going to go there over the summer anyways. And Eric sent them several shunts from his garage. And we trained the Leuven team, or he trained them on site. So these are people who've never played around with the shunts. And so they played around with a model. And then eventually they said, okay, let's see if we can place that into the sheep. And you can see here, this is the shunt, and you can see the outflow of urine from the dilated bladder into the amniotic cavity. And these were the initial feasibility studies that literally are a few weeks old now. You guys are the first ones to see this beyond our initial group. We've never shown this to anyone. And this is what it looks like when you have a pleural effusion model. Jan's group then inserted fluid into the chest. So this is the chest cavity. This is what the sheep looks like. Here's our shunt, and you can see the trocar going into the chest over here. And this is what it looks like deployed afterwards. And again, I want to highlight how clear you can see this shunt deployed in the chest compared to our existing shunts. They then validated the placement of the shunt. So these are the fetal sheep, and I'm sorry for doing this for those of you who have issues with animal studies. But you can see the part of the shunt that is in the bladder here. The fetus is upside down, and this is the outer part. So you can see it's very well placed, and this was in the lung there. So our next steps, really getting additional input from all of you. If anybody has any comments or thoughts, I'd love to meet with you. You don't have to be in MFM or anywhere else. I'd love to, this is a team and a team effort. We're looking at performing additional sheep model studies, both feasibility and, more importantly, of course, clinical efficacy. There's a lot of regulatory stuff that we're working on with James and others in terms of trying to get a shunt like this to be done in humans. We're years away from that. Of course, it takes a fair amount of funding to get that through. It's no longer on the order of tens of thousands of dollars or even hundreds of thousands. And then a part of that is getting more funding. And we were just approved to pitch this again at the upcoming Stanford UCSF pitch competition at UCSF a month from now. And this is really what it's all about. This is Caleb, and I'll end with this.
My name is Sandy, and this is Caleb. While I was pregnant with Caleb, he received 5 separate shunt placement surgeries in order to save his life. And because of the shunt, we believe that is the reason Caleb is here today and has life. And we are really excited to hear about this new design and how it can help so many other kids just like Caleb. Hi, my name is...
And I'll end there. And I think I'm 1 minute over. I was hoping to have time for questions.
We can take a few questions if there's any out there. Yair, thank you so much for just a really exciting, innovative talk. I always learn a lot. Are there any questions folks have? Great. Yair, do you, with your collaboration with biodesign and material sciences, do you see, as you look at some of these other congenital anomalies that you try and treat, do you see that continuing to be kind of an important crux for the advancement of this field? And you're looking at things like congenital diaphragmatic hernia, spina bifida, very briefly, kind of what's on the horizon.
Absolutely, Yair. I think this is just an example as what you're alluding to. We have so many amazing resources here, and there's so many other instruments and tools that we need to either optimize or develop de novo. Not just the tools themselves, but learning more about membrane healing, and which is of course the Achilles heel for fetoscopy in general, and trying to come up with instruments and other things. So yeah, I think this is just going to be hopefully in the long term, just a case study and the first foray into that. But as you said, once you have the sort of roadmap into how to coalesce these teams around these ideas, certainly there's a lot of potential, and hopefully we can not just leverage that, but actually improve, clinical lives and with this. But yeah, this is an area that is really, really exciting. Yeah, absolutely.
Fantastic. And I think we're just perfectly positioned for this here at Stanford. So thank you so much.
Thanks,
and
everyone.
have a great rest of the week and weekend, everyone, until our next presentation. Thanks again.
Bye, everyone.
Bye.
Thanks for the opportunity.